Good evening, everyone. We are so thrilled to have you here for our webinar tonight on deep brain stimulation and Parkinson's, the functional impact and collaborative care strategies. I know everyone is joining from different time zones right now, and we're just really excited to have this webinar featuring our guest host, Dr. Todd Herrington, and I'll tell you about him in just one moment. Here he is. He's the director of Deep Brain Stimulation Program in Neurology at Massachusetts General Hospital and Harvard Medical School. A little bit more about him in just a second. I'll be your moderator tonight just for the introduction and our Q&A and wrap up. My name is Laura Gousset. I work full-time for LSVT Global as the Chief Clinical Officer of LSVT Big. So a little bit about Dr. Herrington. We are so excited to have you and we welcome you to our webinar tonight, Dr. Herrington. Like I said, he's a neurologist and director of the Deep Brain Stimulation Program at Massachusetts General Hospital, and he's an assistant professor of neurology at Harvard Medical School. So brings great prestige to our content tonight. Dr. Herrington completed his BS at Stanford University and earned both his MD and PhD at Harvard Medical School. In his clinical role within the Division of Movement Disorders, Dr. Herrington treats patients with Parkinson's disease, tremor, dystonia, and other related conditions with special expertise in caring for those undergoing deep brain stimulation. His research focuses on how deep brain stimulation impacts motor, cognitive, and psychiatric symptoms of movement disorders. We're so excited to learn from you, Dr. Herrington, from your clinical experience and your research tonight. So please help me in welcoming him to the webinar. And we will also have a short Q&A session at the end for any additional questions that you might have as a clinician joining us through this webinar. A few logistics. If you're new to our webinars, just know that right now your microphones are automatically muted, so there's no background noises from your environments. You can ask your questions in the Q&A, and also you should have received a handout of the slides about an hour prior to this webinar. However, I'll also upload them to the chat tonight, so if you didn't get that, you can download them as well. At the very end, there will be a very short survey that will pop up when you exit. Please do take the time to answer and complete that survey. It gives us a lot of valuable information about this webinar and also future webinar topics that you might be interested in hearing from LSVT Global and other guest speakers that we have on. I want to give you just some basic information on continuing education units and how to report those. If you're an SLP professional, note that this is good for 0.1 ASHA CEUs or 1 contact hour, but you have to watch the presentation in its entirety. If you're joining us live tonight, the survey will launch at the end of the webinar and will be sent in a follow-up email. If you're watching this as an on-demand version or recording, you can find the survey link below the webinar description in the on-demand webinars of your clinician account and in the YouTube webinar description below the video. If you have any questions at all, please email webinars@lsvtglobal.com and we will be happy to help you. Also, just an additional note, if you're wondering about reporting, those are done as one course through the end of 2025. So those reports will be submitted at the beginning of 2026 and will include all the qualifying live and on-demand webinars you attended with your self-assessment survey in 2025. It does take ASHA a few weeks to post-course completion activity in your account, but just note some of these little details on the slides here. There are also a certificate that you can receive whether you're watching this live or on demand. So please be patient with us. It takes us some time to get those certificates out, but it will be on its way. If you're a PT or an OT professional, you can use this as self-reported CE activity. Same rules of the road. Watch the webinar in its entirety, complete the survey, and we will give you a certificate that you can use for self-reporting purposes. If this is accepted or not in your state, please check with your state practice act to see if you can report self-reported activities. The learning objectives are these for Dr. Herrington's webinar with us tonight. By the end of the webinar, you should be able to summarize key features of Parkinson's disease, recognize the primary medications used in PD management, including their basic mechanisms and clinical implementations, explain the purpose and process of DBS for PD, and then identify key outcomes, patient experiences, and the role of PTOT and speech during the DBS process. And lastly, Dr. Herrington will highlight some recent advances in DBS. And with that, Dr. Herrington, I'm going to turn the show over to you. So excited to learn from you, and thank you again for joining us.
Thank you very much. Did you want to stop yours? There it is. Perfect.
Mm-hmm.
Great.
Perfect.
Thank you so much, Laura, for the introduction and for this series, and to LSVT Global for this webinar series and spreading the word about the importance of Parkinson's therapy. And thanks, so many of you are joining late at night, at least on the East Coast. And I imagine that many of you are here because you've had a positive experience seeing the impact of physical, occupational, or speech therapy on the lives of people with Parkinson's disease, and it's made you hungry for more. And we really do, with these kinds of therapies, have enormous impact on people's lives. I suspect you've also cared for people that have deep brain stimulation, and I hear often that deep brain stimulation feels a bit mysterious. And so my hope is to demystify it over the course of these next 30 or 40 minutes or so, and then really to talk with you in the Q&A about how we can really optimally use therapy strategies to improve outcomes after DBS surgery. By way of disclosure, I have done industry-sponsored research and as well as NIH-sponsored research related to deep brain stimulation. I've also consulted for companies that make DBS devices. But my content today is really not specific to any particular brand of DBS device. So everyone on this call knows already a lot about Parkinson's. And so I just want to briefly, to kind of get us all on the same page, talk about the symptoms of Parkinson's disease and basic medication therapy as a way of setting up to talk about what we expect the outcomes after deep brain stimulation to be, as well as some of the challenges that can arise. And then end that section talking about how to integrate physical, occupational, and speech therapy approaches into that process. And lastly, if we have some time, talk through some recent technical advances in DBS therapy. So you may already be aware that Parkinson's in the Western literature was first described in the early 19th century. Physician James Parkinson's describing this classic motor pattern that he saw on the streets of London: a stooped posture, a resting tremor, a shuffling gait, rigid arms and legs, and slowness of movement. And of course, now realize there's quite a broad spectrum of Parkinson's disease presentations, dystonia in younger people, and in the era of good medication treatments for Parkinson's, levodopa-induced dyskinesia, in later stages, increasing postural instability, as well as a myriad of other autonomic, cognitive, and psychiatric symptoms. And we now realize that Parkinson's disease is not just a motor system disease, but really a multi-system disease. But the core motor features, certainly in the earlier stage of the disease, are related closely to the loss of a particular neurotransmitter in the brain called dopamine. So if you look deep here in the brain, an area called the midbrain, in the healthy brain, you have these pigmented regions and the substantia nigra, so-called dark substance. That in the Parkinson's brain, that dark pigmented appearance is absent. If you look under a microscope, these dark pigmented neurons are these plump neurons here, these purple specks on this microscopic photo that are neurons that make dopamine for the brain. And if you look in the Parkinson's brain, you see they're far fewer in number. And if you zoom in on one, they have these abnormal inclusions in them called Lewy bodies that are enriched for a aggregated protein called alpha-synuclein. What's unique about these kinds of neurons, these neurotransmitter, neuromodulator neural subtypes, these dopamine neurons that live down here send their projections all throughout the brain. And so although it's a relatively small population of neurons, loss of those neurons can have a dramatic impact throughout the brain. Turns out that the neurons in particular that are lost early in Parkinson's disease go predominantly to one particular spot in the brain. So this is a kind of scan called a SPECT-SAM that can show us where dopamine neurons are projecting in the brain. This is a structure called the putamen or the striatum. It looks like kind of commas on both sides. In the normal brain, you can see in the Parkinson's brain, the posterior part of that comma, the putamen, is missing. It's lost its dopaminergic innervation. And it turns out that this region right here is in particular the motor part of the striatum or putamen. So the motor parts of the brain, like the motor cortex, connect through this region, back to the thalamus in these loops. And so the loss of dopamine in this part of the brain gives rise to many of the core motor symptoms of Parkinson's disease, that resting tremor, slowness, stiffness, shuffling gait. Thankfully, we have very good approaches pharmacologically to help boost or replace dopamine in the brain. Our most potent agent is still one discovered in the 1960s, levodopa, which is a precursor to dopamine, converted directly to dopamine. It comes in a whole variety of different forms, and now gels that can be infused into the intestine, forms that can be infused under the skin, as well as immediate and extended release forms that it can be taken orally. And there are also medicines that mimic dopamine, so-called dopamine agonists, that also can come in transdermal forms, as well as a variety of other forms. And though levodopa is a very potent and effective medication, as the disease progresses, people begin to develop what are called motor fluctuations. So in the early days, someone might take a dose of levodopa 3 times per day and feel like their Parkinson's symptoms are relatively steady and well controlled. But as the disease progresses, people can develop a variety of unfortunate responses to the levodopa. One is when the dose peaks, or occasionally in other more complicated patterns, people can develop involuntary movements called dyskinesias. And then the medication may not last sufficiently long. So after a few hours, people experience a return of their off, slow, stiff symptoms, so-called wearing off. And people, as the disease progresses, can find that their therapeutic window where they feel like they're on the right dose of the levodopa gets narrower and narrower, and the number of hours in the day where they feel like their motor symptoms are under good control become fewer and fewer. And this is the situation where deep brain stimulation is most helpful. So as you're probably already aware, DBS is a bit like a pacemaker for the brain. There's a wire that's inserted into the brain into specific targets deep in the brain, and then connected via a wire under the skin that goes down behind the ear into a battery unit, a stimulator unit that's implanted in the chest under the collarbone. And currently, DBS is FDA approved for Parkinson's disease, essential tremor, dystonia, generalized epilepsy, and under a humanitarian device exemption, obsessive compulsive disorder. So schematically, what does DBS do? How does it help Parkinson's symptoms? If we imagine that sort of day for an individual who's experiencing motor fluctuations, they wake in the morning and they take a dose of levodopa, the little yellow dots here, and it kicks in and they feel better, but then they develop dyskinesias, involuntary movements, and after a few hours they wear off and they take another dose, and then it kicks in again, and they're riding this roller coaster up and down over the course of the day. DBS helps to both address these off symptoms, helps to reduce dyskinesia, depending on the target in the brain, either primarily or by allowing people to take less levodopa and space the doses out over the course of the day. And so usually people are still experiencing some degree of motor fluctuation, but they're able to take their medicines further apart and they have more good quality time in what they call their on medication state, where their symptoms are well controlled. So here is a video. So it's shared by a DBS manufacturer. So you can imagine, like, it's kind of the best case scenario, the most dramatic effect that you can see of an individual who is off their medicine, so they're not getting the benefit of medicine, and their DBS is turned off on the left and on the right. You see a dramatic response, reduction in their tremor, but also improvement in the velocity of movement. And this is presumably someone who would respond very well to levodopa medicine. So when they take a dose of Sinemet, they'd have a similar response to this, but it would be short-lived. And now, even in the absence of levodopa, can attain some of those benefits of levodopa, but independent of the fluctuating pharmacology of the medication. So DBS for Parkinson's disease has been very well studied. Many clinical trials, at least 8 sizable randomized controlled trials. And so I thought it'd be useful to at least look at a couple of them as a guide to what the expected response after DBS therapy looks like. So this is a common way that in clinical trials, the impact of a symptomatic therapy for Parkinson's disease is measured. And the way it works is that people keep a diary at home, where in usually half-hour increments, they rated for 2 or 3 days in a row how each half-hour increment was in terms of their motor control. And they could either be immobile, which is in that off state, somewhere in between in this study, neither fully mobile nor fully immobile. Mobile without troublesome dyskinesias, this kind of yellowish color is where we want people to be, or mobile but with troublesome dyskinesias, so overshooting a little bit. And if you look at from baseline to 6 months after in the DBS group, there's a marked expansion, about 4.5 hours increased on time, with a reduction in time spent immobile and also a reduction in time spent with dyskinesia. And in another group of patients who were randomized to just have optimizations of their medications, there was no real change over this same period. And so in the course of a waking day, having 4 to 5 more hours of good quality on time is a really dramatic improvement. It also, though, means that these are individuals who are spending a vast majority of their day in an unacceptable motor state when they underwent the surgery. And so after some years, as the comfort with DBS therapy increased, people began to ask, well, shouldn't we be using DBS therapy earlier in the course of the disease? And it's looking at a study with people who had a mean duration of Parkinson's of 7 years, a somewhat younger cohort. They had just begun to experience those motor fluctuations that I mentioned earlier. And now it looked at the impact of DBS on quality of life in Parkinson's disease. They enrolled a group of patients. Some were randomized to just receiving medication therapy, and they were about stable over a 2-year period. Another group was randomized to receive DBS, and lower is better on this quality of life scale. So a reduced impact of Parkinson's on their quality of life, or improved quality of life that emerged during the early months of the therapy and persisted out to 2 years. And that was improved quality of life across a variety of domains, including social stigma, functions in terms of activities of daily living, as well as bodily comfort. So what specific symptoms respond to DBS? Tremor very reliably responds to DBS. And then levodopa-related motor fluctuations, so symptoms that get better with levodopa, but where people are experiencing fluctuating symptoms as they wear off their medicine, specifically rigidity, bradykinesia or slowness, dyskinesia, and dystonia, respond reliably to DBS. And usually the best guide is if you ask someone, what is their typical good on medication state when their medicines are working well? The DBS will help keep them in that state, but it will not tend to make that good medication on state very much better. So if there's something they struggle to do, even when their meds are working, they're likely going to continue to struggle with that after DBS as well. There are some symptoms that only variably respond to DBS. These include problems with speech, balance, gait, and freezing of gait. In particular, when these symptoms tend to fluctuate with levodopa doses, and they may improve after DBS. But we'll talk about these somewhat more in the next slides. And there's some symptoms that don't improve with DBS. These include dementia, atypical Parkinsonian syndromes like progressive supranuclear palsy, multiple system atrophy, or cortical basal ganglionic degeneration, as well as psychosis and most autonomic symptoms. These have an asterisk because sometimes those autonomic symptoms or psychosis are related to on-off fluctuations from the levodopa, or are a side effect of the medicines that we use to treat Parkinson's. And if people are able to lower those medicines after DBS, then there can be some impact on those symptoms too. But generally, one would not want to consider DBS to treat those symptoms specifically. So let's unpack some of these maybe more challenging symptom domains a little bit. What is the impact of DBS on gait, balance, and freezing? And this is driving these conclusions from some meta-analyses, some big summary studies shown below. If you look at the off-medication state, with DBS, there's an improvement in a variety of gait kinematic measures. People walk more quickly, they take longer strides, their time spent in a stride is increased. But when they're on their medication, if you look at their best on state, there's overall, on average, a minimal change in gait parameters. But as many as 10% of patients report some worsening of their gait, including freezing of gait or posture instability, within 3 to 12 months after DBS. So gait is a complex function of the brain, and DBS can, for some individuals, interfere with their gait patterns. So it's important to be sensitive to that, particularly in the early days as we're just introducing DBS after their implant. Impact of DBS on speech and swallowing. So quantitative measurements suggest that on average, there's modestly increased volume and some decreased articulatory precision after DBS. Not huge effects on average in either of those. There's also a small decline in verbal fluency, again, on average, that seems to be a cognitive impact of DBS. If you look at formal swallowing assessments, there's no average impact of DBS on swallowing function, though there are some studies that show a modest improvement and some that show a modest worsening after DBS. And the reality for all these studies is there a high degree of individual patient variability. And so the fact that there might, on average, be a little bit of an increase or a little bit of a decrease doesn't mean that for any of those parameters, there's quite a big distribution. There are individual patients who might improve more significantly or decline in response to DBS. So it's always important to think about the individual patient in front of you and not just the averages of many people. Lastly, the impact of DBS on cognition. Again, on average, studies show a small decline in semantic and phonemic verbal fluency, the ability to generate a list of words that start with a particular letter, or think of as many animals as you can in 60 seconds, the typical clinical assessments used to measure that. There's less consistent declines in measures of executive function, like Stroop test or task switching measurements, minimal long-term impact in other domains. But if you use very sensitive measures, up to 20% of people experience some short-term cognitive impact if measured right after the surgery. And it can even be more significant, like a delirium. But for most individuals, that impact cognitively is mild. There are, of course, from the surgery, more significant complications that can arise. I would say that the one that we worry about the most is bleeding in the brain, intracranial hemorrhage. Bleeding in the brain can cause symptoms like a stroke, weakness on the side of the body, numbness, cognitive problems, speaking problems. A hemorrhage in the brain that causes some symptoms, somewhere on the order of 1 to 2% of cases. and a hemorrhage in the brain that causes a long-lasting symptom, we'd say more than a month, or we think of as permanent, a little less than 1% of cases, speaking for bilateral DBS implants. Also worry about infection. Infection in the skin can be treated with antibiotics, not a terribly big deal. But if an infection goes deeper and involves the implant itself, in many cases, the DBS system has to be removed, or the infected portion of it has to be removed in order to adequately treat the infection. And that, of course, requires a surgery to remove it. And then if you want to have it replaced after the infection is treated, a whole another set of surgeries to replace the device. Other complications are listed here. I won't read each one, but worth mentioning sort of discomfort from the stimulator. I think most people that have a DBS system tend not to notice it all that much. It's a bit like clothing in the sense that no one, you don't, I point out right now, I point out your shirt. Everyone can feel their shirt, but you don't go around all day thinking, I feel my shirt, I feel my shirt, I feel my shirt. So if you're made aware of it, they kind of notice it, but it doesn't tend to be intrusive. But there's some not insignificant minority that experience some discomfort or irritation from the system. So when is the right time to consider DBS? This is a very individual question. And as we'll come to in a moment, we do pretty extensive evaluation for people that are considering DBS to try to really understand what their individual goals are for the therapy. But broadly, say when medications and therapy are no longer sufficient to maintain quality of life, and then obviously when it's a symptom that I think it's likely that DBS could address. But what that exactly looks like for each individual person can be quite different. So it might be that you have a very minor tremor that wouldn't bother everybody, but for you, this degree of medication-resistant tremor prevents you from engaging in a beloved hobby. Or it could be that you're starting to not take longer walks because you're worried that your medicines might wear off halfway through and you might have trouble getting home. Or it could be because you have really significant levodopa-induced dyskinesias and it's been difficult to find a dose of medicine that doesn't induce those but controls your off symptoms adequately. So what does that evaluation process look like for people that are considering DBS? It's really a team sport. This is the DBS team at Massachusetts General Hospital. Many large DBS programs have similar groups that span neurology, psychiatry, and neurosurgery. And it's really a multidisciplinary approach to evaluating each person that's considering DBS. And at least at our institution, everybody that's considering DBS meets with a movement disorders neurologist as well as a nurse practitioner, has an assessment on and off of their Parkinson's medications. They meet with a DBS neurosurgeon as well as a neuropsychologist. And then when proceeding with DBS surgery, undergo MRI scan, and we have a specific protocol here for doing speech and swallowing evaluations as well. The approach to implanting a DBS system varies somewhat from center to center. At our center, we have primarily two different ways that we implant DBS systems. One is the traditional way, using a stereotactic frame, and individual patients are under anesthesia when the whole frame is set up and when the initial incisions are made, and then they're woken up to do what we call microelectrode testing, where we insert a small wire toward the DBS target to confirm it's a good location. We can deliver test stimulation there to confirm that the location is effective and not inducing side effects. And that's been the traditional way that DBS has been implanted since it began. But more recently, and now accounting for about half of our cases, there are approaches for doing DBS in the MRI scanner, under general anesthesia and under direct MRI imaging guidance. And so now, as I said, about half of our people with Parkinson's end up doing the surgery awake with intraoperative testing, and about half under general anesthesia. And then after people have the DBS implant, then they undergo DBS programming, where we are turning on the DBS, adjusting where along the electrode the stimulation is occurring and the other parameters of the stimulation. At the same time, we're starting to reduce their medications typically. And we usually start that process about 4 weeks after the first surgery where the DBS electrodes are placed. And then usually see people about every 2 to 4 weeks for further adjustments. And most people reach a steady state within about 3 months. And patients have a programmer at home where they can make some fine-tune adjustments to their stimulation in between visits under our guidance to kind of fine-tune the settings. And over the long run, there are two different kinds of batteries. There are non-rechargeable batteries that have to be replaced about every 2 to 5 years. And there are rechargeable batteries that can go 10 or 25 years between replacements, but require you to charge them on a regular basis. And DBS benefits are long lasting. There have been studies now that look out 10 or 15 years, and the DBS continues to offer substantial benefit in terms of treating motor symptoms, but it does not stop the progression of the underlying Parkinson's disease. In particular, as the disease progresses, cognitive, mood, autonomic, and other non-motor symptoms can loom larger and are resistant to DBS therapy. And so, one of my charges in kind of putting these remarks together was to think about how we integrate therapy approaches within the context of an undergoing DBS, because we use a great deal of physical, speech, and occupational therapy in the routine course of caring for people with Parkinson's disease, but we have not historically had a standard therapy protocol for every patient undergoing DBS, and putting these remarks together has made me kind of consider what that might look like. The experience of a patient undergoing DBS it's quite intense. There's all the evaluation I mentioned. There's, of course, the big buildup to the surgery, and then this DBS programming period where they have a big surgery where the lead is implanted, and usually the battery is placed shortly thereafter that as a second surgery. And then they have a whole series of programming visits over a period of months, and their symptoms are changing during this period. And it's an exciting time because generally people are monotonically improving over this period, and that's exciting. But there can also be some of these challenges that we have to respond to as the therapy takes hold. And I think that historically during this period, you think about they enter into thinking about DBS, and we're often really emphasizing a multidisciplinary approach to their care with regular use of professional therapy, obviously carefully titrated medications, and really a lot of emphasis on exercise, which I think quite clearly changes the trajectory of people's experience with Parkinson's. And then DBS comes along, and it can kind of like be this force that it takes up so much of their time that they're just so focused on that. And I think also psychologically, when people have a DBS, there can be a sort of mindset like any problem that arises, oh, there must be something to do with this technology to fix the problem. But in reality, we want to really think about DBS as just one piece of their overall Parkinson's care plan. And in particular, I think there's a lot of opportunity for skilled, dedicated Parkinson's therapists to help us identify and address early on some of the challenges that can arise after DBS, like new speech impairments or new balance or gait impairments. But both to kind of as a treatment, but also as a set of eyes to help us identify that someone's functional status, while they might be improving a lot in terms of their tremor, often careful physical therapy evaluation may pick up much better than the clinician's exam, that there are some important changes and negative changes, say, in terms of their balance that we need to try to address with our DBS programming. But also, not just to kind of catch the challenges, but to optimize the gains that people are experiencing. So after DBS, people are often able to get back to activities that they had previously had to forego because of their symptoms. And so I think deep therapy is really an opportunity to encourage people to kind of stretch out a little bit and improve as much as they possibly can from their DBS therapy. I'd love to hear all of your perspective on this as well, and your own experiences with people that have undergone DBS therapy. All right, I want to leave plenty of time for questions, but what I thought I would do is just highlight a couple of recent technological innovations in DBS that are entering or have recently entered clinical practice, just to give you a sense for how the field is evolving. And all of these are, in one way or another, trying to help us get as much of the benefit that we possibly can out of DBS with as few of the negative impacts as possible. And in many cases, let's say thinking about the negative impact in terms of dysarthria from DBS, in some cases, we understand well where that's arising. So the region of, say, the subthalamic nucleus, where when we stimulate, we get an improvement in their off symptoms, is right next to the descending cortical spinal tract, or cortical bulbar tract, that if we stimulate that cortical bulbar tract too much, will induce articulatory problems. So you need to figure out how can you deliver as much stimulation as you need to the part that's going to give you a therapeutic benefit and not have it spill over into the regions that are going to cause side effects. And I'm just going to say that there are now 3 companies that are making DBS devices. They're all innovating in their own ways, and so it's really an exciting time technologically in DBS, where things are now moving in a good clip, and there's innovations coming out year by year, which is great for all of our patients. But in terms of this idea that can we deliver stimulation a little bit more precisely, all the companies now offer what are called these steering electrodes, where we're able to deliver stimulation out one side of the DBS electrode. And we exclusively implant these kinds of electrodes at this point. And you might imagine that helps us to shift current or stimulation towards the areas that are most beneficial and away from those that cause side effects. And so reasonable evidence that helps to optimize outcomes, particularly for patients who have a more challenging or less tolerant of the DBS stimulation. Also, the early days of DBS programming are really entirely based on clinical assessment. So the neurologist or the nurse practitioner would test one stimulation setting and do an exam, and then test another one, do an exam, and just based their selection purely based on that. But increasingly now, we generate these 3D models of DBS electrode location. And we have learned over the years about where anatomically we tend to have benefit and where we run into side effects. And so, in addition to directly observing how the stimulation is affecting that individual person, we have a sense from the imaging about where, on average, we would expect the stimulation to be most effective. And so we can sort of start sampling there to speed up the process, or we can take another look there if it wasn't identified in our first programming attempt. And similarly, we have an idea about what regions are most associated with side effects. So if we're experiencing some of those side effects, we can use the imaging to help us steer away from those. And these are now built into the programming tablets that we use now right there with the patient. So we're able to integrate that information in our stimulation plan. And then the last thing I want to remark on is this notion of adaptive stimulation or closed loop stimulation. So I showed this little schematic of an individual with fluctuating motor symptoms over the course of the day. And the way we deliver stimulation right now, typically, is what's called continuous DBS. So we figure out the setting that that seems to, on average, help that individual the most, and we just leave that stimulation on 24/7. But you might imagine looking at this might not make a lot of sense that we're delivering the same stimulation when their medicines are peaking and they have dyskinesia, uh, and then that same exact stimulation when their medicines are wearing off and they have their off symptoms. So the notion of adaptive DBS is if you can actually sense brain activity that gives you a biomarker for when they need more or less stimulation, could you customize your stimulation to be responsive to these different brain states? And so there's one, various biomarkers have been proposed. The one that is entered as of earlier this year into clinical practice is adaptive DBS based on beta band oscillations, which is a biomarker you can record from the brain that correlates with slowness and stiffness in Parkinson's. Here's just an example from one patient. This is looking at a week's worth of data. This is an average day. Noon is in the middle, 6 a.m., 6 p.m. You can see this biomarker is increased. I'll tell you this is shortly after the person wakes up, and then it kind of falls, then it comes up again, then it falls, then it comes up again and falls. As if you look, this is exactly when they were taking their Parkinson's medicines. They would feel slow and stiff. They'd take a dose of medicine, they would kick in, they'd feel better. They start to feel slow and stiff. They take some Parkinson's medicine, and it kicks in, and they feel better. And they're on this fluctuating cycle over the course of the day. What an adaptive DBS lets us do is just now looking at the the amount of DBS therapy delivered, is to conform that to their underlying biomarker, to have a little more stimulation when they're off, a little less stimulation when they're on, in the hopes that we can more optimally control their off states and back off and perhaps cause fewer side effects when stimulation is less necessary because the medicine is doing the heavy lifting. Okay, that is it. And 15 minutes left for questions. So let's see if some have been coming in on the webinar. Happy to take any questions, but thanks so much for your attention.
All right. Thank you so much, Dr. Herrington. That was extremely interesting. And I think we do have a few questions in the Q&A. First one is, how do you determine who will be awake versus asleep during the DBS surgery?
Oh, yeah, that's a great question. So patient preference has a huge impact on this at this point. There are a few symptoms like tremor that respond very reliably to stimulation, so they can be quite well tested in the operating room. And so if someone has a lot of tremor, we do often present the idea that this is something we think we can very reliably test in the OR. On the other hand, someone might have very severe painful cramps or dystonia if they're off medicine, which is required to do the intraoperative testing, or maybe just have a great deal of anxiety, and the idea of being at all awake in the operating room is just too intimidating. Those might be individuals where we encourage very early on to just do the asleep surgery. But for many people, it's somewhere in between. We know how to do both approaches. Some people have read about it or watched videos online, and they come to the surgeon saying, I've seen these videos of the guy that plays the violin in the operating room, and like their vision of DBS is the awake procedure, and that's really kind of what they're expecting. And other people are like, boy, if you could put me asleep and do it, I absolutely want that approach. So we listen a lot to what each individual person wants.
Yeah, that makes sense. I can definitely see both sides of that for sure.
Yeah.
Next question is, how does DBS actually work? You discussed the effects, but what's the mechanism? Is it dopamine production, released, or stimulation of receptors, etc.?
Great. Yeah, I didn't talk about that at all. So it is not dopamine. So you might ask then, well, if it's not dopamine, why does it seem to, in a sense, replicate the effect of dopamine? And that's still a good question. I don't think we have a very adequate answer for. But I mentioned this beta biomarker, this beta oscillation. What that is actually is a reverberating activity in the brain that's around 20 hertz, somewhere between 13 and 30 hertz. The actual individual frequency varies from person to person. But this is an abnormal oscillation that entrains within this sensory motor circuit in the brain And it turns out that there, in addition to just that oscillation, there's other kinds of brain activity that become then entrained to it. It's like the brain is stuck in this abnormal rhythm. And that rhythm is particularly strong in the sensory motor basal ganglia, these nodes, in a part of the basal ganglia that's connected to that region that's lost dopamine. And it's that the intensity of that oscillation in the brain seems to correlate at least with the slowness and stiffness that people experience from their Parkinson's. And we observe that therapy like levodopa, in this case, right, tends to desynchronize this abnormal rhythm, and DBS works in a similar way. So if you deliver DBS to these
Mm.
nodes where this oscillation is occurring, we desynchronize it, and that beta band oscillation falls away. So there are probably lots of mechanisms by which
Yeah.
DBS is working rather than a single one. But this is at least one where we can observe that this brain is in this abnormal, stuck in this abnormal pattern of oscillation.
Mm.
And by delivering stimulation, we can break it out of that abnormal oscillation and let it return to a more normal pattern of dynamic activity. So
Mm.
that's at least one mechanism by
Yeah.
which we think DBS works.
That's interesting. Great question. And I haven't heard that great of a response before. So thank you for that. Okay, the next question, I think this is really interesting, and a question I had too is about these assessments of therapy prior to DBS. Not all hospitals are open to them. Maybe some of them haven't even considered having baseline assessments by PTOT speech prior to DBS. Any suggestions for what we as PD specialized therapists can do to advocate for patients to be assessed by us prior to surgery? And is there any research we can pass along?
I love this idea,
Mhm.
and I'll tell you really the practical challenge
Mhm.
uh, is just how much we already ask of people
Mhm.
in this process. So they come in, for example, we used to try to do everything in one day where they would come in off
Yeah.
medicine in the morning, and then their medicines would kick in. They're meeting, with us throughout that process. Their medicine's kicking in. They're meeting with the neurosurgeon. They're having neuropsychological testing, and they often had a
Mhm.
baseline MRI scan that same day. And
Mhm.
then at some point, it became just so much for people. These days were just too exhausting. So we ended up kind of splitting it up. But we're in a busy metropolitan area in Boston. It can be a big challenge for people to come into the city. It's not easy. And so, just from a simple practical standpoint, it can be hard uh, to have the person also go down to the busy therapy practice and on every time for a baseline. And so
Mhm.
I kind of I alluded to this in my remarks that I made when I was kind of
Yeah.
talking about integrating physical therapy, is that we have had speech therapy integrated over the last couple of years, really as an initiative of the head of our functional neurosurgery program, Dr. Richardson, has a particular interest in speech function in people with Parkinson's. And it's enormously helpful to have that
Yeah.
information. So this actually for me, like one of my
Yeah.
growth areas coming out of this to say, all right, I
Yeah.
need to reach out to some of my physical and occupational therapy colleagues and
Right.
just explore how we could do that. Because I do think neurologists pride themselves on their their exam, their kind of clinical acumen for being able to dissect, what the specific motor problems that a person's experiencing. But
Mhm.
as I'm sure I'm preaching to the choir, physical therapists and occupational therapists, speech therapists, they have a whole different sensitivity
Yeah.
to the kind of real world impacts of these Parkinson symptoms. And so I think it would be an extremely valuable other set of eyes and ears if we could figure out how to do it just practically.
Yeah. Sounds like a great study that we could do. And I agree. As personally having been part of a DBS team as a PT in the past, I think there was value in having some, really detailed information about gait and balance and function and ADLs and speech, a parameter, a variety of things as a baseline and to help guide the team in determining is this a patient really the best candidate for DBS and what might we want to really look at when we're looking at that placement of the lead.
And
So yeah,
how long were your evaluations typically, Laura?
an hour, an
Yeah.
hour for each discipline, but they were not done on that same day. They'd have been done maybe a month prior or something like that. So the data was there to reflect on as the neurologist.
Yeah.
Yeah,
So you had them come back for an
yeah,
hour assessment with speech, OT, and PT
yeah, yep,
each. Wow.
yes,
Yeah.
yeah. That would be the dream team, I think. Yeah,
Yeah.
yeah,
I agree.
yeah. And
Yeah.
then afterwards, I think always having the opportunity to see them again after their DBS has been optimized a few months later is wonderful because they have a kind of a new body that they're working with and maybe some new challenges and new opportunities as well with that.
Absolutely.
Okay, great. Let's go on to the next question. We have great questions, guys. Thank you so much for asking these. Could you describe who you would consider to be a good candidate for DBS? For example, do clients need to do a trial medication for a certain number of years before they're eligible? And what's the criteria?
Yeah. Yeah. So this is always a really tricky question to answer because people with Parkinson's differ so much one from the other, and their individual goals differ so much, right? So that's kind of the point I was making on, back on this slide where I tried to,
Mm,
imagine these different people who, they seem to have very little in common in terms of what
yeah.
our goals are with the therapy. But what they share in common is that they have a symptom from their Parkinson's that we've tried to optimize medications and therapy, and you can't address it adequately. Right. So this symptom is now really negatively impacting their quality of life. And it's a symptom that we know is likely to be improved by DBS. Right. So that could be that they've got some
Mhm.
residual tremor that we can't dial out with medicine, and we can't find a good occupational therapy strategy to help them deal with that. Or they've got wearing off that impacts their gait, and you've done all the physical therapy approaches to kind of build that up, and they're exercising, and you've titrated their medicines, but they still wear off halfway through a 3 mile walk. And so they're not going to take those walks anymore. And that might only happen 10% of the time, but it's scary enough when it happens that now they're not going to
Yeah,
walk at all, even though they could have done it 9 times out of 10. Or it might
mhm.
be the person who is wildly dyskinetic and has really uncomfortable dyskinesia, and you just cannot thread the needle there of finding
Yeah,
enough medicine. So it's hard to find a single strategy, or even to say like, well, they need to have been on, this number of medicines for this number of years, because that too
mhm.
depends. Each There's no single criteria that I think you need to meet, that every person needs to meet.
Mhm. Mhm.
So
Mhm.
I tend to frame it more in these terms: is like, what's the problem you're trying to treat, and have you
Mhm.
adequately tried other things to do it, rather than setting up sort of maybe a little bit more arbitrary, kind of universal guidelines.
That makes complete sense, right? No two people are the same.
Yeah.
Yeah. Okay, a few more questions, and then I think we're almost out of time. So we'll do our best, everyone, to get to your questions. Is there a steady increase in the use of DBS every year, and has the number of procedures increased over the last 5 to 10 years?
Yeah, it is steadily increasing, and so the number, the DBS case volume keeps going up, but it is still, I think, dramatically underutilized. I think there are many
Mhm.
people with Parkinson's that never hear about it, or they hear about it and they think of it as a last ditch Hail Mary sort of approach that they would use, rather than what it really is, which is a therapy to maintain quality of life.
Mhm.
Uh, and so I think it's still a challenge we have, just educating. And I think the therapy community can be really involved in that effort too. When they see someone who
Definitely.
is experiencing these fluctuations or is really bothered by their tremor and um, it's impacting their quality of life, to know that there is this therapy, that they should be asking their team about it.
Absolutely. Yeah, thank you for that. Next
Oh,
question
I
is,
just
yeah,
oh,
yeah.
just one other thought about this, about who's the right candidate for DBS.
Oh, yeah.
Because it's not the other, I think, important thing is and this is why I think the goals of the patient is so important. We spend a lot of time trying to really understand that individual patient's goals, because it's not, we have all these scales where we measure symptoms, but some people with Parkinson's tremor have dramatic Parkinsonian tremor and it barely bothers them, right?
Mm,
And so
mm-hmm,
that's someone who, if if they have balance problems and a
mm-hmm,
dramatic tremor, and what they're bothered by is their balance,
mm,
you'll make their tremor a lot better, and all your scales and all your metrics will look like they're markedly better after DBS, but they won't be happy because they
mm-hmm.
wanted their balance to be better. They want to be able to walk better.
Good point.
Uh, and so
Yeah.
I do think that's really the critical piece of this, is making sure you know what that person really wants out of this.
Yes. Yes. Good point. Good point. All right, I think maybe one last question here. Our learner said, I believe you explained EBS does not stop the progression or the decline. You did. Does it have any long-term negative side effects? And what's the follow-up process of DBS, like an annual checkup, twice yearly? And with that, Dr. Harrington, I would also like to add to that, as a therapist, if you're seeing someone who maybe had DBS a couple years ago or something like that, are there any indicators that you'd like, yeah, you should report that to the neurologist as their therapist?
Yeah. Yes. So uh, it is always hard to ask questions scientifically about long-term impacts. So
Mm,
you can study the long-term people that have had DBS for a long time, but you of course don't have an exactly matched population that at the same point didn't get DBS that you follow over the similar period. You know, when people have done that, or when people have looked at people that have had DBS, say for 15 years, and at that point turned their DBS off and done studies that, well, how much is it impacting their their um, their life at that point? It's clear that the positive impacts of DBS are maintained out for, well over a decade. But that also these underlying symptoms like freezing of gait, postural instability, worse postural control in general, these cognitive symptoms, these other things that are not strictly dopamine related and that are probably related to the spread of degeneration to a broader brain circuit, that these are things that are not so responsive to DBS. But
mhm,
it seems in the data are not heightened by DBS either. So I think that the caution uh, I would add to that, and this is something where I think as a therapist, your input could be very valuable. Is sometimes these things sneak up on us. So you might say, why does a neurologist not immediately know if the DBS setting is affecting their gait, for example?
mhm,
And it turns out that uh, sometimes side effects like impacts on gait and speech that can be negative are delayed. So
mm,
you turn on a stimulator setting in the office, they walk in the hallway and they look great, right? It's not until the next day or a couple of days later that the gait problems start to emerge, right? And so probably something like that happens sometimes, where someone's speech or their gait is declining subtly over time, and we don't appreciate that DBS is contributing to that in a negative way. And we try to say, okay, well, let's try to adjust stimulator settings, or in the office, we'll even turn someone's DBS off briefly and try to see, is it impacting their speech or their gait. So that's something that if patients have their own programmers,
mhm,
uh, they can turn their own DBS off. Many patients are comfortable doing that, and will do that if they're going to have an MRI scan, for example, or a little surgical procedure. And so if it's within your comfort zone, within the patient's comfort zone, I think you can do a test where you have the patient turn their stimulator down a little bit or even
mm,
off briefly.
mm.
And under your watchful eye, you can assess, well, what's their
Okay.
speech like when I do that? Or what's their gait like when I do that?
Mm,
And that can be an instructive thing both for the patient and for the the provider. And if you do
mm-hmm,
identify that there seems to be really clear impact, say on speech or gait, that's negative,
mm-hmm.
it's something for them to surface with their DBS programmer and decide if there's more of an exploration to be done there.
Mm. Okay, that's a really interesting answer. Thank you for that. All right. Well, I want to be respectful of your time and our attendees' time as well. So we're just going to do a few wrap-up slides. Again, thank you everyone
Which one?
for your questions tonight. Yeah, we'll go to the next one. If you do have questions, email us at info@lsvtglobal.com and we can try to help you with those questions about DBS as well. We've had some other previous webinars that might be of interest to you as an LSVT Big or LSVT Loud certified clinician. This webinar has been recorded, so if you missed a bit, you'll be able to watch it on demand as well. The survey will display for live participants as soon as you log off. And for on-demand webinar participants, you should find the survey link below the webinar description. If you can't find it, email webinars@lsvtglobal.com. Survey is super short, so please fill it out. A couple of other slides that we have for you here. Just a reminder, we have a podcast. It's been very popular, helpful. We have a range of speakers and presenters that come to our podcast, so please check that out. And lastly, if you have any questions at all, email us at info@lsvtglobal.com. If you are a therapist and have patients that might be interested in this topic, there will be a community webinar tomorrow at 2 p.m. Eastern with Dr. Herrington. Same information, but really focus more on a patient and caregiver audience. This is a free webinar tomorrow. You can email lsvtglobal.com if you can't find the registration link and information, and we can send that to you. We'd love to have your patients, family members, etc., join that webinar tomorrow, or maybe you have colleagues. So with that, thank you once again so much for your time, your expertise, your knowledge, your insights, Dr. Harrington. It was a wonderful webinar, and I wish we could stay on longer, but this was a really good introduction.
Lovely. Well, wonderful to meet you and thank you all for joining.
Thank you. Good night.